Good morning. This is Emily Henderson with the Kentucky Hospital Association. I'm pharmacist and work with the Kentucky Statewide Opioid Stewardship Program, or Kentucky SOS. We are excited that you have joined this month's webinar as we learn together Kentucky. If you are currently logged on or logging on, please make sure your phone or computers are muted so we limit the distractions with background noise. On today's call, we also have members of the Kentucky SOS team, Melanie Mock and Claire Arant, along with myself, Emily Henderson, pharmacist at the Kentucky Hospital Association. So without further ado, I would like to introduce our guest speaker today, and so kind of Dr. Barones to offer his give his expertise to further our efforts, our opioid stewardship efforts here in the state. So Dr. Adam Barones is CASPR epidemiologist at the Kentucky Office of Inspector General, Cabinet for Health and Family Services. Today, his title of his presentation is entitled CASPR, Drug Overdoses and Pandemic Prescribing, which is very appropriate in the time we're living. So Kentucky SOS welcomes Dr. Adam Barones. Adam?
Well, thank you very much, Emily. It's a pleasure to be invited to speak today. I will try to do my best throughout the presentation to field questions through the chat box. So if you do have questions, let me have them and I will get to them as I can. So I do not have any financial relationships or other conflicts of interest to disclose today. The brief outline of my presentation is as follows. I will be talking about Kentucky fatal drug overdoses, as well as non-fatal overdoses in the year 2020. I'm going to take a deep dive and I'm going to assess the impact of the COVID-19 pandemic as it relates to Kentucky controlled substance dispensing. And then last, I will talk about CASPR reports, CASPR enhancements, and relevant CASPR research that is relevant for this presentation. I think the best way to start off is a statistic. And so there's a considerable overlap among the residents in Kentucky who die of a fatal drug overdose and pharmaceutical prescriptions that are in CASPR, our drug program. And so approximately 60%, in fact, 60% of Kentucky residents who fatally overdosed in the year 2020 were dispensed at least one controlled substance prescription within 1 year of their date of death. This is a jarring statistic, and it's an associative, correlative statistic, right? I'm not saying that one causes the other, but I am saying that there is overlap and there is a relationship. So I will show you some evidence looking at this as we move forward about this known relationship between individuals who are prescribed controlled substances and then those who fatally overdose in the future. According to the 2020 Kentucky Office of Drug Control Policy Report, I took this quote off to set up my study that I did looking at how the COVID-19 pandemic influenced prescribing and dispensing in the state of Kentucky. And so reading this, the Office of Drug Control Policy believes the global pandemic caused by COVID-19 was a major contributing factor in the rise of overdose deaths across the United States and in Kentucky. The interruption of routine, and that's really what prompted me to do my study, is interrupting care. For those in recovery, have suffered a great deal, especially those who need that stability. In the time of pandemic, when things are very uncertain, can lead to a sense of isolation, loneliness, economic concerns, and anxiety all contributed to the dramatic increase recorded. So it's plainly obvious that the COVID-19 pandemic itself, from a viral point of view, has had a certain healthcare impact. But then the tangential related aspects in terms of policy, whether it was inadvertent or not, has a major impact on prescribing. I'm going to show you some slides on this. So I did a study. I looked in an epidemiological relevant way. I looked at, I focused on plotting. I looked at graphs, and I wanted to see, in summary, according to the World Health Organization, they declared the pandemic on March 11th, 2020. So I wanted to create a pre and post view of that. I did 120 days before March 11th and then 120 days after March 11th. And I did that for 5 years. So I did that over year so that I could isolate the effects of 2020. And you'll see those plots in a second. So this is what I did in terms of the overview and the methods. I wanted to evaluate Casper dispensing following the declaration of the COVID-19 pandemic. So March 11th, the World Health Organization declared coronavirus the global health pandemic, and there were restrictions and cancellations of elective procedures and so forth. And as an epidemiologist with OIG, I wanted to quantify these effects. So I looked 120 days before and 120 days after March 11th for 5 years. So we're talking about November 12th through July 9th for a given year. So it was a longitudinal repeated measures design, and it allowed for a year-over-year direct comparison centering on this March 11th date. And it's a very clean line in the sand. And so I used a linear model. I did a multiple pairwise comparisons with a 2-key test. I came up with p-values. I'm not going to show the technical statistical approach that I did, but that's what I did. I created a linear model, and I modeled this, and I followed it up with 2-key post with multiple means comparisons. So I used 5 years of Casper data, and my primary outcome measures of this study were the number of prescriptions dispensed per day. Right, these are controlled substance prescriptions dispensed per day, the average metric quantity dispensed per day, and the average day supply per day. So I'm getting ready to show you a series of 8 graphs. We're going to look at a few different drug classes. We're going to look at opioids. We're going to break out. We're going to look at buprenorphine by itself. We're also going to look at psychostimulants. And then last, we're going to look at benzodiazepines and other sedatives. So I'm going to call those my 4 drug classes. And then we're going to look at the 2 outcome measures, primarily the metric quantity and day supply. I'll get into the prescriptions because the prescriptions analysis turned out a way that was unexpected to me. I'm going to jump right to the conclusion before I show you those graphs. This is what I found. In conclusion, the metric quantity, right, how many units, how many pills, and day supply increased for opioids, buprenorphine, psychostimulants, and benzodiazepines and other sedatives in the state of Kentucky immediately after the pandemic. And remember, this is my pre-post study that I did 120 days before March 11th and 120 days after March 11th. That was a statistically significant trend. However, the number of prescriptions dispensed per day was not significantly different. I did 120 days for this study, and then I shortened the window to make sure that there wasn't a difference seen within 60 days, 30 days, and I even did a week. And I'm not finding a significant difference in the number of prescriptions. So in summary, for opioids, buprenorphine, psychostimulants, benzodiazepines, and other sedatives, the amount prescribed in terms of the day supply of the prescription and the metric quantity issued was greater after March 11, 2020. Let's look at some figures to understand this a little bit better. Here are the 8 charts that I was talking about. So here you're looking at opioids. First thing, when you interpret a graph, you have to see what I'm labeling it so that you know what I'm actually doing. On the x-axis, you have the date filled. You can see I've got 5 years, 2016, 2017, 2018, all the way to 2020. And then you see a white dotted line. right next to the year. That white dotted line for each year is March 11th for that year. The dashed white line is March 11th for that year. So the spread on the left side of the dotted line matches the spread on the right side of the dotted line, which is 120 days before March 11th and 120 days after March 11th for a year. On the y-axis of this chart, you're seeing the average days supply. This is how many days the prescription was supplied for. Let's jump right to 2020. Do you see the dramatic increase after the dotted white line in the day supply for opioids? A trend that is not evident in the years before. Doing it this way, you can clearly see how the day supply shifted from around 22 and it jumped up maybe to 23. That was a statistically significant jump. Immediately jumped up, the day supply jumped up, and that's for opioids. The metric quantity for opioids had a similar trend. Year over year, you could see a very stable pattern before March 11th for each of the previous 4 years. And in 2020 in Kentucky, you can see for opioids, following the declaration of the pandemic, you can see an obvious increase in metric quantity. And on the y-axis on this one, we're talking about metric quantity. These are the number of dosage units dispensed. Went from around 70 or so, and it hopped up right around 80. So there was more metric quantity that was prescribed. The prescriptions did not change. There was not I did not see a statistically significant difference in number of prescriptions. I did not show the graphs for this, but I wanted to show the graphs for the trends that were statistically significant. So those are two graphs. Now we're going to look at our third one. We're going to do buprenorphine and then psychostimulants and then benzodiazepines and sedatives. You can see for the day supply for buprenorphine, following the declaration of the pandemic, an increase in day supply. However, buprenorphine was a different drug in terms of the relationship in the years before. I would caveat the finding in 2020, although it is significant. There was also a significant difference in 2019, where after 2019, March 11th, buprenorphine day supply was increased to 120 days after versus the 120 days before. So there's a confounding influence of time, which tells me for buprenorphine, although in 2020 the day supply increased, we have seen that trend before, and it was actually in 2019. The same relationship occurred for metric quantity regarding buprenorphine. You can see a relatively stable pattern for the first 3 years, 2016, 2017, and 2018. And then 2019, there's a significant jump that was also seen in 2020. So in isolation, 2020, buprenorphine, there was a greater amount supplied after the pandemic, but that was seen in 2019, which to me is a confounding influence. Therefore, I can't be sure that the pandemic itself was responsible for that shift. Moving forward, we have psychostimulants. I looked at psychostimulant day supply as well as the metric quantity. You can see the day supply, the yellow lines after after March 11th, how it breaks out like that, how it jumps up. There was a statistically significant increase in psychostimulant day supply that was not seen in any year previously, indicating that the pandemic was associated with an increase in day supply for psychostimulant dispensing. Metric quantity followed a similar pattern. This was significant as well. The yellow lines after March 11th increased, where they did not the years before. Breaking it out, you can clearly see the difference. This is my last class of drugs, benzodiazepine and other sedatives. I included Z drugs like zolpidem and Lunesta, right, Ambien, Lunesta, and so forth. The day supply for these drugs increased whereas the years before they did not. COVID-19 influenced benzodiazepine dispensing in the state significantly. The metric quantity followed a similar relationship where the amount prescribed, metric units increased in a way that was not seen in the years before. Coming back to my conclusion slide, in summary, the metric quantity and day supply increase for opioids, buprenorphine, psychostimulants, and benzodiazepines and other sedatives in Kentucky immediately after the pandemic, which was a statistically significant trend. The number of prescriptions dispensed, however, did not change. So the number stayed the same, but patients got more. Looking at some existing reports for drug overdose trends in 2020, we had some favorable statistics. In 19, it was a slight increase. In 2018 statewide, the numbers dropped after a heavy lift and a statewide effort that involved so many stakeholders. 2019 increased just a little bit beyond that. And in 2020, as we know, the drug overdose fatalities really jumped. Drug overdose, the non-fatal overdoses jumped as well. And so we're dealing with a raging epidemic of physical drug dependence. I'm not encouraged. I've seen some numbers for 2021. This is preliminary. I'm not encouraged that we've got a handle on this. The drug epidemic this year is so far burning wildly. Looking back in 2020, though, ED visits for drug overdoses, you can see a clear pronounced peak in May of 2020, and then a gradual taper off of ED visits for non-fatal drug overdoses among Kentucky residents thereafter. So again, you saw a peak here for emergency department visits regarding non-fatal drug overdoses, peak in May of 2020, and then sort of taper off thereafter. It's clearly a result of a number of factors, but the burden and the stress and the isolation is evident here in these ED visit numbers. The fatality statistics are disheartening and show no signs of slowing down so far this year. As I've mentioned, in 2020, more than 1,900 Kentuckians died from a drug overdose in 2020. That was approximately a 50% increase in the numbers seen in 2019. An opioid was involved in 90% of all of those deaths, and fentanyl was detected in more than 70% of all cases in Kentucky and nationwide. And so the story for 2020 is a story of fentanyl. Looking at the geographical component, the top 5 counties regarding age-adjusted per capita deaths, Knott County was number 1 for resident deaths by county, followed by Clark, Bourbon, Henry, and Carter. Geographically, you can see that some of these counties are in Appalachia, some are not. Looking at the maps, and I took these from the 2020 Kipper Community Data Summit. You can see 2017, the top left map. To the right of it, the 2018 drug overdose map. This is the age-adjusted drug overdose deaths per capita. 2019, bottom left, and then you see the real takeoff in 2020, where especially in the area of Greenup County, Boyd County, Carter County really started to light up. Then you have Central Kentucky, such as Bourbon County, Clark County, really started to light up as well. And so you can see the focus in Central Kentucky and Eastern Kentucky, where 2020 was a very terrible year for drug overdose fatalities. Again, the story is a story of fentanyl in 2020. Approximately 71% of all overdose deaths for that year, about 1,400 cases involved fentanyl. When you look at the breakdown by age, I did a comparison. I did a 2019 to 2020 comparison looking at the counts. I wanted to see, well, which population, which age group is experiencing more of the burden, right? If we had a 50% increase in fatalities from 2019 to 2020, Is it a proportional increase spread evenly among the age groups, or is one group or the other rising more quickly than the others? The 45 to 54 year age group was the only group that showed a decrease of about 4 percentage points. So the middle-aged folks, the 325 count at 2019 that went to 405, the relative proportion of that age group, the 45 to 54-year-olds, there was about a 4 percentage point drop among the middle-aged. However, there was an increase from the 15-year-olds to the 44-year-olds from the 2019 to 2020 of a few percentage points per group, for a total of around 4% increase for that group. Said differently, younger people, 15 to 44, relative to 2019, experienced a higher rate of drug overdose fatalities seen in 2020. And there was a decrease in the 45 to 54-year-olds. Did not run a statistically significant test to determine if the numbers were significant, but that is the proportion differences. This is a stacked bar graph over time. You can see, just looking at 2019 to 2020, the tan and peach color, how that shrinks a little bit. And then the light blue from 2019 to 2020 is a little larger. That represents what I'm trying to say here. The younger folks comprised more of the deaths in 2020 than they did 2019. And there was a little bit of a minimization or a squashing, so to speak, of those that are middle-aged and older. Using toxicology testing results from 2020, the top 5 drugs found in the postmortem toxicology screen include fentanyl, 4-AMPP, which is a fentanyl metabolite, methamphetamine, amphetamine, and morphine. Looking over the yearly counts of the drugs involved for the fatalities among Kentucky residents year over year, starting left to right, you can see fentanyl really jumps from 2019 to 2020. As we know, the potency is pronounced. Fentanyl, off the charts, right? Methamphetamine, steady increase. There was a little bit of a jumping up that took place in 2020 for methamphetamine. As we know, the drug epidemic mutates and shifts depending on the supply. The demand seems to take many different forms. And so the cheapest drug that can get you high the quickest tends to be the drug that is consumed, right? Methamphetamine imported, that's potent, that's cheap, that's available, explains these methamphetamine increases. To the right here, you see the counts as well by other drugs. Looking at the top left of this panel on the right here, benzodiazepines. We were seeing a year by year slight trend decrease. 2020 increased that for benzodiazepines. Heroin has remained steady in recent years, has decreased from the 2016, 2014, from before that. Essentially has been replaced, not replaced, but overtaken in a way, I guess I could say, by fentanyl. Coming here, cocaine, a slight increase for 2020, relatively stable. Hydrocodone and then oxycodone. As we know, many individuals begin their drug addictions with prescribed opiates. Those numbers are relatively stable. Gabapentin seems to be ever present in the postmortem toxicology results, jumped up in 2020. Down low, you can see fentanyl analogs. And it's really a cat and mouse game, because the state can afford to procure a certain number of designer panels, right? There's the standard stuff, there's the designer stuff, and then there's the arms race between detecting what is being created, whether in a lab or in someone's garage and so forth. So these designer panels are expensive. And you can only measure what you can only assess what you can measure, right? Just because if you didn't measure it, then you don't know. So taking that into consideration, fentanyl analogs have increased. But I suspect, and I've been on national calls, especially in the New England area, I'm hearing reports of designer benzodiazepines, increasing in the postmortem toxicology in Kentucky. I'd like to see that information, but if you don't test for it, you can't quantify it. And so it's easy to say that it's not there. So just be mindful of, we're only qualifying those metrics that we can assess. And there are others, and it's an arms race to determine what they are. The designer panels are expensive, but they're very useful. Going back to my statistic, controlled substances, this relationship between receiving a prescription, a controlled substance prescription, and then dying of a drug overdose. The individuals in 2020 who died of a drug overdose were dispensed, 60% of them were dispensed controlled within 1 year of their date of death. Let's talk about Casper. We'll look at reports, some viewing tips, some enhancements, some approaches that we've taken as an agency to address the opioid epidemic from a illicit point of view, and some of our partners that we've engaged with research studies that have helped to shine light on the findings within our system. Casper was born in 1999. In those days, it was a fax-based system. And in a few years after allocation of funds, the system was able to be launched in a web-based format. 2005 is when eCasper was launched. And we're getting ready to modernize and update and renovate our system in 2022. There'll be a massive makeover, so stay tuned for changes coming to Casper next year. Casper does not track Schedule I drugs, such as cocaine, methamphetamines. We track Schedule II through V scheduled drugs. Now, viewing the report itself. So the Casper report itself has a wealth of information that's useful in a clinical environment. Working the top down, the first thing that you should look at is the between dates. It's when the report was run. In this example, I'm looking at a report run from October 22nd, 2019 to October 21st of 2020. It's the from date and to date that makes all the difference in the world. When you query Casper, you have at your fingertips you have the current year plus 2 years to look back, and that's our production server, right? You have the current year plus 2 years. And so there's a time delay, right? Because we don't have the prescriptions in our PDNP that were dispensed today. It takes time for them to make it to our system, to stage the record, to ensure that it meets the quality, and then that it's in our system. So there's a few days of latency. So the range that you run the report, everything is going to hinge on that to date between X and Y, right? So moving down the report, our active cumulative morphine equivalent, or ACME figure. Now, our report has been since modified to flag those that are above 90. We followed the CDC guidance on that. This is the active in terms of the to date that you requested on the report. That's the most current view of our database, where the prescriptions are, the opioid prescriptions contribute a morphine load. And so looking at this 150 value, you can see that the column for daily MED, 120 plus 30, those prescriptions for which an opioid, for which an MED or MME can be calculated are added. That sum total is provided here in this box to give you an idea, according to the to date on the report, how much morphine a patient is currently on. Ideally, we like to have our system streamlined, where the moment it was dispensed, it could be input into our system with either minimal delays or no delays. And I think the future of PDNPs will try to minimize the latency period between when a prescription drug was dispensed and when it's available for querying, right? the narrower we can make that window, the more useful our report will be, because it will actually be what's happening today or at worst yesterday. Okay, going back up towards the top of the report, you have who requested the report. You have a request number. This is what we call a rec ID or a request ID. You can call our office if you have issues with your report. Provide this number and we can look into it. You have patients that match the search criteria. If you have more than one patient that match the search criteria, you'll have a patient ID number, 1, 2, 3, 4, so forth. This patient ID field is the person that behind the scenes matched. And over here on the column on the actual table of the report, you can see patient ID corresponds to that person. So the 2s and the 1s in the patient ID column over here on the right side of the report corresponds to the matched patient that your query returned. That causes some complications sometimes. And at that point, sometimes you'll notice one will see issues such as a blend where a father, son, or twins get pulled into the same report. These are infrequent issues, but they do happen. So be mindful of the patient ID and ensuring that because people move, right? Sometimes the date of birth gets inputted incorrectly. People change their names. And so our algorithm underneath the scenes is doing the best job it can to match the right patient across all those changing parameters. You see a line graph over time for the period that was queried. You can see the red line is at 100. We've since moved that recently to 90 to reflect CDC guidance. And you can see the black line that represents the morphine load over time. The line over time can be very helpful for looking at irregular patterns, whether on the prescribing side, doctor shopping, excessive NME over time. This black line is a trend line of morphine that one should pay attention to. Looking at the table itself, you can see that the registered DEA city is what's listed for the prescriber. It's not where the patient was seen. Right? When the prescriber registers with DEA, it's the primary practice location, but that could be Northern Kentucky. But I actually saw the patient in Lexington. It's going to say Northern Kentucky, Florence. So the prescriber DEA city is where the prescriber registered with DEA in terms of their primary practice location. You have the provider name, prescriber name listed. You have the pharmacy name. If a provider is a dispensing physician or dispensing practitioner, their name will appear for the pharmacy. Don't be alarmed if you see a doctor's name for the pharmacy. That means that that doctor dispensed the drug. You have the pharmacy city. You have a column over here called RPT2, reported to. So in this case, you see all KY Kentucky. But if you see Indiana or Illinois, it means that that drug record was reported to that PDNP from that state. And when you query other states, when you run a Casper, if there is a match in Indiana, Illinois for that patient, as indicated by their PDNP, it will say reported to Indiana. And you know that record was reported to Indiana's PDNP, but it's being visualized in our report. So the interstate feature is very important. I'm going to talk about that in a moment. But the reported to is where that drug was report, what system it went to, right? Was it Tennessee? Was it Montana, and so forth? The date filled of the drug, the generic drug name with the strength. You have the patient date of birth, the metric quantity, the day supply, and that's our basic Casper report. We've enhanced our system. Our application is constantly undergoing renovation. We have a prescriber report card, or these PRCs. This is a valid statistical approach to assess how you prescribe controls, how your peers prescribe controls, and how the state prescribes controls. We have bar graphs, we have dial graphs, we have table totals, we have percentages. We also have an at-risk section that lists the patient name with the date of birth for those that may be at risk. At risk is defined as an overlapping opioid with a benzo, or for any patient that may be seeing multiple providers. call those multiple provider episodes. If I see more than 5 prescribers in a 6-month window, that's a potential flag that could be investigated. It's listed on the report that you can find in your account maintenance screen that gives you insight into your patient's behavior so that you are not contributing to any malfeasance or negligence. The statistics I help contribute with the statistical analysis, I stand by these numbers. You're looking at opioids, benzos, psychostimulants, and you also have an MED or MME graph that compares the strength of your opioid. These are available in the quarterly formats, annual formats, and we have tracking statistics so I know who's viewing these. We would like these numbers to be higher because we believe that this can really help your practice. CASPR has also been enhanced with the linkage regarding the administrative office of the courts. There's a rolling 5-year window that for regarding Class A misdemeanor and felony drug convictions. If queried, if our system is selected to query, the AOC system is selected to query, you can see information regarding previous drug convictions. That information is available to make a decision. This was an enhancement that we put on a few years ago. Not fewer than 10% of the queries look at the administrative office of the court's drug conviction data. And there have been surveys that University of Kentucky has done regarding the understanding of this means perceptions, how it's used, how do I take this into consideration? Because there was a time, and I think there probably still is confusion regarding how this can be used, right? If I have a patient who's got a swollen knee from a basketball game on the weekend, who is convicted of moving oxycodone 2 years ago, do I no longer, can I not prescribe an opiate to this patient who's got a felony drug conviction for trafficking opiates? These are the types of challenges that providers and pharmacists that think about, and University of Kentucky has quantified. We're always looking to improve our system. IIDS, our project manager regarding integration, Jean Hall, came up with this idea. She's done an incredible job where the rubber meets the road, getting this deployed. I've worked alongside a team of developers, analysts, pharmacists, to project managers to dig into what our information says. As Jean has said, she believes there are patterns in our data that are useful for our partners across our borders. And so what we've done at the state recently, within the last 2 months, we've deployed this algorithm. You can now use a mathematical and geographical algorithm to have states suggested to you, other states suggested to you to query without thinking about it in a way that could be helpful for you. The geographical component is regarding if a patient, for example, is from New York and you're CASPering them, New York gets pulled in by default. If you run a CASPR on a patient that lives in, let's say, Kenton County. Kenton County is a border county with Ohio. Ohio gets pulled in by default. That's the geographical basis in a nutshell. There's a mathematical basis as well. If a given prescriber in Kentucky for a zip code, let's say 40511 in Lexington, prescribes controlled drugs to a lot of Oregon patients, Oregon gets pulled in to the prescribers who are associated with 40511 in an effort to use our data mathematically, where there's a likelihood, a higher statistically likelihood that Oregon dispenses should be relevant. Therefore, we recommend querying Oregon. We have states that are grayed out. We cannot query those states because we don't have data sharing agreements in place with those states. Again, this algorithm has been deployed for around 2 months now. We will be evaluating the effects and the usefulness of this, but it is a mathematical and geographical algorithm that can dynamically suggest other states to query, and we're proud of it. We're also proud to have worked with the University of Michigan. Colleen Carey, Giacomo Mayo, and Thomas Buchmuller at the University of Michigan engaged us with a study They wanted to evaluate House Bill 1. Now, humbly, I say this is the best evaluation of House Bill 1 that I've ever seen. They published this just recently in Health Affairs. They showed, and you can see the graph on the left here, before the mandate of House Bill 1, right, you have to use Casper, in July of 12. When the mandate went down, the number of queries on the left, you can see that the lines take off. When you mandate it, they use it. Pain management is the larger user, according to this study, querying Casper. They broke it down by other specialties such as primary care, surgical, emergency, and so forth. You can see that the graph on the left illustrates that the number of queries to our system dramatically took off. The graph on the right shows they stratified this by patient status, and they looked at opioid naive, chronic, and high-risk patients. Without digging into the details too much, you can see that the bar graphs decrease. And what they're showing is, irrespective of the colors for now, just look at the decreasing bar graphs, that fewer prescriptions were issued after the mandate. They're showing that after you mandate the PDMP, providers are looking at the Casper report that they issued fewer opioid prescriptions. Using Casper, according to their words, has a significant association with a decline in prescribing. Let's look at how they described it. Our findings suggest that the Kentucky mandate had the desired impact. Providers responded to the information revealed from queries by reducing opioid prescribing to patients with high-risk patterns. A number of states have followed Kentucky's lead in implementing a comprehensive PDMP mandate, although providers of PDMP use is still voluntary in many states. Our findings suggest that these states could reduce opioid prescribing to high-risk patients by mandating use of their PDMPs. Our goal is to help clinical decision-making. We want to have the best of information available to you, our end user, so that when you're in the clinic, you're making the decision, that you have all the information that's relevant for safe and effective controlled substance prescribing. We're also proud to have worked with the University of Louisville. Dr. Martin Hecker, and I actually contributed on this study. Jacob Schreffler did an amazing job. Isaac Shaw did an incredible job. We worked together to look at overdose decedents in Jefferson County. These are opioid overdose decedents of Jefferson County. Among the other findings, they showed, and you can see this, it says figure 2 visualizes the days from the latest buprenorphine prescription fill date to accidental overdose death. For the 110 individuals with a buprenorphine prescription, the median days of survival from the last prescription to opioid overdose death was 343 days. Approximately 50% of the decedents, the people who died of an opioid overdose in Jefferson County, 50% of them were alive 1 year after their last buprenorphine prescription. There's a relationship. If you're on buprenorphine and you don't maintain buprenorphine, the increase in the likelihood for death goes up. So if you start, this is evidence, direct evidence to suggest that you need to maintain that. And also in their paper, but not shown, is this concept of seesaw prescribing. If you are a patient and you're getting buprenorphine, and then you go to a different doctor and they prescribe Vicodin, it's counterproductive at that point, right? The seesaw prescribing, they characterize it as seesaw prescribing, then they go back to buprenorphine, and back to Vicodin, and back and forth. We do not like this. Research does not support this. Seesaw prescribing opiates to those who struggle with opioid use disorder can be mitigated by reviewing the Casper and making the best clinical decision with the information that we're trying to provide. You see, the University of Louisville also looked, and I think this is the real take-home message, and this ties in the message that I've been bringing up, this relationship between overdosing and pharmaceutical drugs. Individuals in Casper were 2.4 times more likely to have an oxycodone, hydrocodone, hydromorphone on postmortem tox than those who did not have Casper data. And that's right here. You can see oxycodone, hydrocodone, hydromorphone, that the decedents who died of an opioid overdose were more likely to have a Casper record. In addition, individuals in Casper were almost 2 times more likely to have a benzodiazepine in their system at the time of death. When you're in Casper, there is this association to fatal overdoses. I'm not saying it's causative. I'm not saying I'm saying it's a correlative and it's evident, right? And as I conclude my presentation, I wanted to make mention of this initiative that we have at the state with Dr. Connie White with the Department for Public Health and IG Adam Mather with our office here, and postpartum opioid prescribing. Now, this is a report that I do that has manifested into a statewide initiative that we're proud to execute. We're looking at a critical window. Women who are prescribed narcotics after their delivery within 1 week of that delivery. And so it's a vulnerable time period for many, because for many women, that is the first time that their body will have experienced an opioid. So it's very important that the prescribing is commensurate with the need. If you don't need to prescribe 12 oxycodone 5s a day, then why are you? The trend line in red represents cesarean births, looking at the number of dosage units have decreased over the last several years. We're proud as a state to see this relationship. You can see the blue line for spontaneous vaginal births regarding the number of solid dose units prescribed to these women within 7 days of their delivery. These are uncomplicated births, have also declined. We're heading in the right direction, but we want to make progress. That's my presentation. I appreciate the time. Can I take any questions?
Thank you, Adam, for this presentation. This is Emily Henderson with the Kentucky Hospital Association. At this time, we will take questions either in the chat box or unmute yourself and ask Dr. Barones directly. Also, this presentation, you will be awarded continuing education. We will put the portal instructions up on the screen. This is all continuing education is offered for medicine, pharmacy, and nursing. Kentucky SOS is always proud to get continuing education as we further our program in the state. The portal instructions are on the screen. You will see the access code. Be aware of the expiration date. If you have not completed the evaluation to receive continuing education by October 29th at 11:59 p.m. Eastern Time, you will not be able to receive continuing education. We do not have control over that. That is through our continuing education administrator. Again, this window, however, for continuing education will not open until 12 noon. So you have a few minutes, but please utilize this for medicine, pharmacy, and nursing continuing education. Are there any questions for Dr. Barones at this time? I have put in the chat box his email if you should have any questions later. Also, like all Kentucky SOS webinars, this webinar, we will send the slides and the recording out to all project leads, and it will also be posted on the Kentucky SOS website at Kentucky, spell out KentuckySOS.com. You can find past webinars there also. Are there any questions at this time? I know there was a lot of information and information that we can all learn from also regarding prescribing and treating pain for our patients in the state. You're getting some accolades. Any questions for Dr. Barones And I do want to say just a personal thank you to Dr. Bronis for offering to be available. If you should have questions regarding the Casper report or any of this information today, feel free to email him directly, or you can always email me at ehenderson@kyha.com to get in touch with him. Okay, well, if we had a great great participation. I saw many physicians, pharmacists, nurses, and senior leadership on today's webinar. Let's see, hang on. Okay, thank you. There is a question, when will the webinar be available to watch? Some have logged on, weren't able to log on right at 11 a.m. Give KHA's media department about a week and we will post it on the Kentucky SOS website, but I will send out an email to all the project leads and others on our distribution list when it is posted and the recording is available. So, but it typically takes about a week, usually less, but other things come up. So, okay. So don't forget to log on and get your continuing education. Again, that won't start until 12 noon. Thank you, Dr. Bronis, so much for your time and expertise. And also, we have lots coming up regarding Kentucky SOS education for the month of October, November, and December. They're already planned. So be looking and be watchful in the Kentucky SOS newsletter and calendar invites for upcoming events. Thank you so much for joining today and all that you do across the state to further our opioid stewardship efforts. If there are no further questions, have a great day and we'll talk soon.